Now, coming towards the spleen, what is spleen and what is spleen trauma? The scenario is that there is a 10-year-old child, injury to the left lower chest, X-ray shows fracture of the left lower ribs, and having tachypnea, tachycardia, and BB is 80/60. So, what is the diagnosis and the treatment? Another scenario is a patient having abdominal pain, faint, dizzy, and pale, sweating. BP is 100/60, and the pulse is 110. The diagnosis, investigation, and treatment, and what are the post-op complications? The causes of spleen trauma are blunt injury, abdomen, injury to the left side of the chest, lower left ribs, fracture due to fall from tree or RTA, road traffic accident, retroperitoneal hemorrhage, fracture spine, and renal injuries. Now, blunt injury, abdomen. Penetrating injury, spontaneous rupture of the spleen is seen in malaria and infections, mononucleosis. Iatrogenic spleen capsule may be toxin during surgical procedures such as vagotomy or gastrectomy, and the clinical features are divided into three groups. The first one is tearing of the splenic vessels, which is avulsion of the splenic pedicle, can result in severe hemorrhage and shock. Death can occur within few minutes. The second one is slow developing hemorrhagic shock followed by recovery, anemia, pallor, pulse 71 per minute, BP low or hypotension, cold clammy extremities, and guarding and rigidity. Kehr sign is positive, that is irritation of the undersurface of diaphragm by blood causes irritation of the phrenic nerve, that is C3 and C4. Thus, this pain is referred to shoulder region, that is supraclavicular nerve. Note: Kehr signs can be elicited by elevation of foot end of the bed for about 10 minutes. What are the complications? These are hemorrhage, the shock, multi-organ failure if not treated, DIC, injury to tail of the pancreas, splenic artery pseudoaneurysm, splenic AV fistula. The investigation options are emergency ultrasonography, which is the most important. It reveals splenic injury, hematoma, and other injuries. CT scan is done, which should be used in doubtful cases and stable patients. DPL, that is diagnostic peritoneal lavage, is done. It is indicated in the blunt injury of abdomen. HB% estimation of pec cell volume and 4-quadrant top aspiration is done. Plain X-ray abdomen is done. It shows splenic rupture, obliteration of the splenic outline, fracture of one or more lower lips, elevation of left side of the diaphragm, and free fluid between the gas filler and intestinal coil. Now, what are the treatment options? These are the conservative management, which is the careful observation in the ICU, make patient hemodynamically stable, CT scan to confirm absence of highlight involvement or massive disruption of the spleen, close observation with regular monitoring of the vitals. Then surgery is done. Then emergency splenectomy is done. Active bleeding due to large laceration leading to hypotension, emergency splenectomy is treatment of choice. Then partial splenectomy is done due to problems in total splenectomy. Partial segment of the spleen is resected, done in children. Splenography is done, which is the method to preserve spleen when general or condition of patient is reasonably good. So what we have studied the spleen or spleen trauma. We discussed the two scenarios, that there is the history of fall and the pain, and the clinical features are the hypotension and the sweating and the rapid pulse. So what are the causes? The causes are blunt injury abdomen and the injury to left side of the chest, and the in penetrating injury, the spontaneous injury, the iatrogenic. Then we discuss the clinical features, which are divided into three groups. The first group contains the tearing of splenic vessels. The second group contains slow developing hemorrhagic shock. Then we discuss the Kehr signs. Then we discuss the complications. Then the investigation options, which are emergency ultrasonography, the CT scans, the diagnostic peritoneal lavage, then the HB estimation, then the plain X-ray abdomen. Then we discuss the treatment options, which are the conservative management and the surgical management. Then the emergency splenectomy. In surgical management, we are having the emergency splenectomy, the partial splenectomy, and the splenography. Okay, now coming towards the splenectomy and its clinical features. There is a 20 years old admitted for investigations of anemia. Investigation shows a hereditary spherocytosis in large spleen requires splenectomy. So, how we will prepare the patient? What are the complications and what are the causes of splenomegaly? The indications and are the traumatic, that is blunt or penetrating injuries of the upper abdomen or lower chest, or iatrogenic injuries. The first one is red cell disorder, the second one is platelet disorder, the third one is white cell and bone marrow disorder, and the fourth one is miscellaneous. Okay. Now, in the first one, we are having hereditary spherocytosis and sickle cell anemia and thalassemia, and in the acquired, we are having the autoimmune hemolytic anemia. In the platelet disorder, we are having the idiopathic thrombocytopenic purpura, the thrombotic thrombocytopenic purpura, and the in the white cell bone marrow disorder, we are having lymphomas, Hodgkin's disease, myelofibrosis, CML, and AML. In miscellaneous, we are having the hydrated disease or cyst, the abscess, the portal hypertension, the splenic artery, and the aneurysm. Now, what are the pre-op prep? These are coagulation profile should be done, should be corrected, DVT, antibiotics, and vaccination is done. Spleen is very important part of the immune system. Splenectomy imparts small but definitive risk of life-threatening infections. When splenectomy is planned, vaccination against encapsulated organisms should be given at least 2 weeks before surgery. Most commonly, infectious organisms are streptococcus, pneumococcus, and H. influenza type B and meningococcus. The vaccinations include polyvalent pneumococcal vaccines should be given to patients older than 2 years undergoing splenectomy. Meningococcal vaccine can be given as a one-time vaccine to patients greater than 2 years of age. H. influenza should be given if not given during infancy. What are the causes? The causes are malaria, viral or bacterial infection, typhoid fever, lymphoma, cirrhosis, HIV, rickets, heart failure, ITP, hereditary spherocytosis, tumors in spleen, and thalassemia. Now, what are the complications options? These are intraoperative and early post-operative. Intraoperative are hemorrhage, bowel injuries, injury to the colon and stomach, injury to the tail of the pancreas, and diaphragmatic injury. In the early post-operative management, we will okay. Then we are having the complications of late post-operative complications. These are opportunistic post-splenectomy infections, and the pulmonary complications are atelectasis, pneumonia, pleural effusion, sapropharyngeal abscess, wound infection, hematoma, post-op ileus, and post-op gastric dilatation. So we have discussed the splenectomy, the scenario, then the clinical features, then the indications which are traumatic, then we discuss the red cell disorders, the platelet disorders, the white cell bone marrow disorders, and then the miscellaneous. Then we discuss the pre-op prep of the patient, then we discuss the vaccinations that are included for the patient, then what are the causes, then what are the complications. These are intraoperative and early post-operative and late post-operative complications. Now coming toward the hepatobiliary system. Okay, the first topic we will be discussing is cholelithiasis, which is also known as gallstones, and which is very important topic in surgery. Gallstones are the commonest biliary pathology, that is 10 to 15% of population are affected from gallstones. The pathogenesis is cholesterol stones and the pigment stones. In the cholesterol stones are common in the increased age and in the female and in the obesities and in the western diet. And it should be remembered with 4 F's. This is that is female, above 40, fatty acids, and the fertile. Okay. Now the pigment stones are contain less than 30% of the cholesterol. These are black and brown pigmented stones. In black, these are insoluble bilirubin and calcium phosphate plus calcium carbonate stones and hemolytic disorders, and it is hard laid out surface. The brown pigmented stones are infections of the biliary tree, and the causes are gram-negative bacteria and E. coli and Klebsiella and bacteroids and fragilis. The calcium palmitate and calcium stearate and calcium bilirubinate are the causes of pigmented stones. Now, what are the consequences of gallstones in gallbladder, in bile duct, and in the intestine? In gallbladder, these are asymptomatic, and the biliary colic, acute cholecystitis, chronic cholecystitis, empyema of gallbladder, mucosal, perforation of the gallbladder, and gangrene of the gallbladder, and carcinoma of the gallbladder can occur due to the in the consequence of the gallstones. In bile duct, biliary obstruction can occur, causing obstructive jaundice, and the acute cholangitis, acute pancreatitis, and cholangiocarcinoma can occur. In intestine, gallstones, ileals can occur. Okay, now what are the asymptomatic gallstones? There are no indications for cholecystectomy done in special circumstances. Cholecystectomy should be performed in diabetic patients, in hemolytic anemia patients, in pediatric and young age group, in family history of the gallbladder cancer, acromegalic patients who are on long-term somatostatin analog therapy, porcelain gallbladder, calcification of the wall of gallbladder. It is risk factor for carcinoma of the gallbladder. Then gallstones discovered at laparotomy performed for some other reasons if general condition of patient is good and patients undergoing bariatric surgery, morbid obesity. So these are the cholecystectomy should be performed found in these conditions. So we have discussed that what is the cholelithiasis. These are the stones in the gallbladder. Then what is the pathogenesis and what are the types? These are cholesterol stones and pigmented stones. And there are two types of pigmented stones. These are the black pigmented stones and the brown pigmented stones. Then what are the consequences of gallstones? These are in the gallbladder, in the bile duct, and in the intestine. Then what are the asymptomatic gallstones, and what is the cholecystectomy, and when should be it performed in the cases of the gallstones? Now coming towards the acute cholecystitis, what is the scenario? We are having a scenario that there is a 45-year-old female, pain in right hypochondrium radiating to back for last 3 hours. Pain is associated with nausea, vomiting, and mild pyrexia. Abdomen is standard below right costal margin and is painful when took deep breath. What are the differential diagnosis? What is the first line of treatment, and what are the complications, and what are the investigations and management? Okay, now acute calculus cholecystitis, it is the impaction of stone of gallbladder, that is Hartmann pause, and hyperemesis edematous and tense distended abdomen is present. Now what are the clinical features? These are the right upper quadrant bent radiating to back, tenderness in the right hypochondrium, anorexia, nausea, vomiting, fever, mild jaundice may be present. Now what is Murphy's sign? It is a respiratory arrest during deep palpation of right upper quadrant occurs due to touching of the inflamed gallbladder. What is Boy's sign? This is the hyperesthesis of skin below scapula. What investigations we will do for the case of the acute cholecystitis? We will do the leukocytosis, then the ultrasonography, that is thick wall gradient and 3 mm of gallbladder, and pericholecystic fluid and sonographic Murphy sign. Then the radionuclide scan, that is HID scan, shows non-filling of gallbladder even after 24 hours of injection of radiolabel HIDA. Then sequelae of acute cholecystitis is that the resolution, then empyema, then mucosal, then the gangrene, and the perforation occur. What are the treatment options? These are the surgical. In the surgical, we will do the early cholecystectomy for 3 to 4 days and the internal cholecystectomy for 6 to 10 days. Then the internal cholecystectomy, we are having the open cholecystectomy and the right coccus incision. Now the treatment of choice is cholecystectomy. What is the procedure? The procedure, first of all, resuscitate the patient, then nil per oral, antibiotics, analgesics, and intravenous fluids are given. Then acute cystitis of 3 to 4 days of pain. Conservative treatment is NPO, then antibiotics, intravenous fluids, and analgesics are given, and the patient monitoring is done. BP, pulse, and temperature is done, and the complications are worsening of symptoms despite of conservative treatment, reduction of the gas in the biliary tree, empyema of the gallbladder, established generalized peritonitis, development of intestinal obstruction, gangrene, or perforation of the gallbladder. Okay, so we have discussed the cholelithiasis. Then we discuss the acute cholecystitis, the scenario of the acute cholecystitis, then what is the acute calculus cholecystitis, then we discuss the clinical features, the Murphy signs, the Boy's signs, then the investigations, that is leukocytosis, ultrasonography, radionuclide scan, then the sequelae of acute cholecystitis. Then we discuss the treatment options, the treatment of choice for cholecystectomy and the procedure, the surgical, that is early cholecystectomy and the internal cholecystectomy, then the open and the cholecystectomy and the right coccus incision, then the conservative management, then we discuss the complications. Now coming towards cholecystostomy. Cholecystostomy. Percutaneous cholecystostomy is a technique that consists of percutaneous catheter placement in gallbladder lumen under imaging guidance. Secretions of the gallbladders are drained and inflammation is settled. There are operative hazards and there are contraindications. The operative hazards are injury to the bowel or great vessels, damage to the common bile duct, the portal vein, the hepatic vein, failure to complete procedure, CO2 retention due to absorption of intraperitoneal CO2, accidental perforation of gallbladder, and scattering of the calculi. The contraindications are severe chronic obstructive pulmonary disease, the congestive heart failure, the severe bleeding disorders, and the end-stage liver failure. The complications of cholecystostomy are damage to the hepatic duct or common bile duct, damage to hepatic artery, biliary leakage leading to biliary peritonitis, mesh stone in common bile duct or cystic duct, wound complications, that is hematoma, infection, or incisional hernia. The post-cholecystostomy syndrome are heterogeneous group of disorders after cholecystectomy, and the causes are retained or recurrent calculi in the common bile duct, gallbladder, or cystic duct, remnant bile duct structure, and other unrecognized iatrogenic injuries, the papillary stenosis, and the biliary dyskinesia. Acalcular acute cholecystitis is the cholecystitis without stones and common in patients of sepsis, burns, major operations, and multiple traumas. Okay, so we have discussed the cholecystostomy, that what is it, then the operative hazards, the contraindications and the complications, and the post-cholecystectomy syndrome, then the causes, and then the acalculous acute cholecystitis. Now coming towards the choledocholithiasis. We are having a scenario that there is a 50 years old man having a previous history of gallstones, recurrent onset right hypochondrium pain, pruritus, dark urine on examination, jaundice. Investigation shows increased bilirubin and alkaline phosphatases. So, what are the investigations, complications, and treatment options? History of cholecystectomy, jaundice, and ultrasound shows dilated common bile duct. These are the diagnostic points for the diagnosis of choledocholithiasis. Stones may be small, large, single, or multiple. Now we are having if primary stones then form within bile duct in response to infection of biliary tree or by parasitic infestation of the biliary tree. They are usually brown pigment. Secondary stones migrate from gallbladder into bile duct and are usually cholesterol stones, may be asymptomatic or lead to cholangitis, pancreatitis, or obstructive jaundice. Now we are having a Courvoisier's law which states that the obstruction of the common bile duct occur due to stone that is not palpable, and the obstruction of the common bile duct occur due to any other reasons, carcinoma head of pancreas or cholangiocarcinoma, then the head is palpable. Okay, this gives us to state that if the obstruction of the common bile duct occur due to stone, then it will be not palpable. But if the obstruction of the common bile duct occurs due to any other reasons, that is the carcinoma head of pancreas or cholangiocarcinoma, then the head is palpable. Now, what investigations we will do? We will do the ultrasonography, the MRCP, that is magnetic resonance cholangiopancreatography, ERCP, that is endoscopic retrograde cholangiopancreatography, and during attack of cholecystitis, increased bilirubin, alkaline phosphatase, and total leukocyte count will be checked. What are the treatment options? We are having the surgical treatment option. This is ERCP, endoscopic retrograde cholangiopancreatography, choledochotomy, which is done laparoscopically or open surgery is done. We are having T-tube cholangiogram after choledochotomy, then choledocoscopy, then ERCP and PTC for retained stones. Then supraduodenal choledochotomy, cholecystectomy or choledochotomy plus choledochoduodenostomy, then pre-op ERCP plus sphincterotomy or the for the entrance of stone followed by laparoscopic cholecystectomy. These are the surgical options. The pre-op treatment is treat liver failure if present, high intake of glucose to build up stores of the liver glycogen, then vitamin K 10 mg intramuscular or intravenous or fresh frozen plasma to correct clotting derangements. Blood culture is done, broad spectrum antibiotic according to blood or clinical features if there is cholangitis. Renal failure must be prevented as these patients are more prone to renal failure. Avoid dehydration and give intravenous fluids, that is dextrose 5%. Okay, so we have discussed the choledocholithiasis. We are having a scenario. Then we are having the diagnostic point, that is the history of cholecystectomy, the jaundice, and ultrasound well shows the dilated common bile duct. Then we are having different types of stones. These are primary stone and the secondary stones. Then we are having Courvoisier's law, which states that in which cases the stone will be palpable and in which case it will not be palpable. Then the investigation options. These are ultrasonography, MRCP, ERCP, and we are having treatment options. These are surgical and pre-op. In treatment, we are having ERCP, choledochotomy, T-tube cholangiogram, choledocoscopy, and ERCP, supraduodenal choledochotomy, cholecystectomy, and choledochotomy, plus choledochoduodenostomy, and pre-op ERCP plus sphincterotomy. The pre-op preparation of the patient, then we are having the cholangitis. Now let's discuss the cholangitis. We are having a scenario that there is a 50-year-old patient which is having yellow discoloration of the eyes and skin and having fever and pain right upper abdomen for 1 week. There is history of cholecystectomy 1 year ago. So what are the causes? How will you do the assessment? And what are the treatment options for cholangitis? Cholangitis is the inflammation of the biliary channels. Obstruction lead to contamination of bile by bacteria. The common causes for cholangitis are gallstones, biliary structures, parasites, Ascaris lumbricoides, biliary stents, choledochal cyst, biliary tract instrumentations. The common organisms are E. coli, Klebsiella, pneumonia, and Pseudomonas. The clinical features are common in elder female and having fever, epigastric or right upper quadrant pain and jaundice, Charcot striate, in 2 by 3rd patients. The fever, epigastric or right upper content and jaundice is known as Charcot's triad. The Raynaud's phenomena, that is fever, jaundice, right upper content pain, septic shock, and mental stages changes are present. Now, the investigations that are done are leukocytosis, hyperbilirubinemia, increased alkaline phosphatase, transaminase level. Ultrasound is done for gallstones, dilated bile ducts, and biliary obstructions. The treatment options are intravenous antibiotics are given, intravenous fluids are given, analgesics are given. Emergency biliary channels decompression, that is common bile duct stones, must be retained by ERCP or stent placed to drain bile. PTC if ERCP is not successful. So we have discussed the cholangitis, the scenario, then its definition, then what are the common causes and what are the causative organisms, then the clinical features, then what investigations are done for it and what are the treatment options. Now coming towards the pancreas, and we are having a topic acute pancreatitis, which is very important. So we will discuss this in detail. We are having a scenario that there is a 40-year-old vomiting and there is a 40-year-old patient who is vomiting and epigastric pain radiates to back. Pain is severe and gradual in onset. On examination, patient is agitated and sweaty and is unable to lie flat for examination and vomits persistently. BP is normal, pulse is 120 per minute, and acute pancreatitis was diagnosed. What are the differential diagnoses? What is the grade of severity? What are the causes? What are the management? And what are the complications? The definition that we are having for acute pancreatitis is acute inflammatory process of pancreas with variable involvement of other regional tissues or remote organ systems associated with raised pancreatic enzymes in blood or urine. Now, what are the causes? These are gallstones and alcohol for 80% of the cases. It can be remembered from GET SMASH, that is G is gallstones and biliary tract disease 40%, E is ethanol, alcohol 40%, and post ERCP. T is for toxins and drugs, steroids, thiazides, diuretics, estrogen, and azathioprine. S is for surgery or trauma, post splenectomy, Whipple's operation, blunt and penetrating trauma of abdomen. M is for metabolic, for example, primary hyperparathyroidism, uremia, diabetic coma, pregnancy, and hyperlipidemia and mumps. A is for autoimmune, S is for snake bite or scorpion bite, H is for hypothermia, D is for divisum, pancreatic divisum, duodenal ulceration, and I is for idiopathic. Okay, now what are the clinical features? These are severe upper abdomen pain which radiates to back and relief with sitting or leaning forward. Retching, nausea, hiccup, bluish discoloration of the flanks occurs due to the subfacial bleeding, gray tunnel sign, or occur around umbilicus collar signs. Pleural effusion occurs in 10 to 20% of the cases, and abdominal distension and ileus occur. Now, what are the investigation options? These are lab diagnosis, that is serum amylase and lipase is done. Increase immediately, remains elevated for 4 to 5 days. Level increase up to and fold. Lipase elevated in 76 to 90% of the cases and remain elevated for longer time than amylase and more specific than amylase. Imaging is done, that is ultrasonography of the abdomen, not such as satisfactory due to the presence of bowel air to detect gallstones and rule out cholecystitis. CT scan is done, which is gold standard investigation for the diagnosis of pancreatitis and indicated when diagnosis is uncertain. In severe acute pancreatitis, to distinguish interstitial from necrotizing pancreatitis, patients with progressive clinical deterioration and local complications are suspected. That is abscess, necrosis, and pseudocyst. Laparotomy is done mistakenly for suspicion of peritonitis. Plain X-ray abdomen is done, blood and urea examination, and serum calcium level. These are the investigations that are done for the case of acute pancreatitis. Now, how we will assess the severity of the case? For mild acute pancreatitis associated with minimal organ dysfunction and has uneven full recovery, 25% is mild pancreatitis, while mild pancreatitis is 1% mortality. In severe acute pancreatitis, it is associated with organ failure or local complications such as necrosis, abscess or pseudocyst is called severe acute pancreatitis, and the mortality rate is 20 to 50%. Then we are having Renson's criteria, which is having 11 parameters, 5 at the admission and 6 after 48 hours. At admission, the age should be greater than 55 years, WBC greater than 16,000, blood glucose greater than 200 mg per dl, sodium lactate dehydrogenase greater than 700, aspartate aminotransferase is greater than 250. After 48 hours, hematocrit decrease and greater than 10%, blood urea nitrogen elevation greater than 5 mg per dl, serum calcium less than 8 mg per dl, RTL PO2 less than 60 mm of Hg, best deficit greater than 4 milliequal per liter, and estimated fluid sequestration greater than 6 liter. These are the parameters after the 48 hours. Okay, then the other criteria that okay, for mortality, the number of Ranson signs and approximate mortality percentage is, if it is if the points are from 0 to 2, then the mortality rate is 0%. If the points for Ranson is 3 to 4, then the mortality rate is 15%. If 5 to 6, then 50, and if it is greater than 6, then 70 to 90% of the chance is there for mortality. Now we have another scale, that is Glasgow scale. At admission, the age is greater than 55 years, WBC count greater than 15,000, blood glucose greater than 200 mg per dl, serum urea greater than 16 millimole per liter, and partial pressure of O2 is less than 60 mm of Hg. Then within 28 hours, serum calcium less than 2 millimole per liter, serum albumin less than 32 gram per liter, LDH greater than 600 units, and aspartate or LT greater than 600 units. Okay, now the above 8 Glasgow 3 or more C-reactive protein is greater than 150 and worsening of the clinical conditions. This shows the severity of the disease. So from Ranson criteria and from Glasgow scale, we can assess the severity of the acute pancreatitis. Now we are having the management options. First of all, it is done as A, B, C, D, E, and F. For A, aspiration with Rayleigh's tube to give rest to the pancreas. For B, blood transfusion if HB is low or albumin and acid levels are low. For C is to check the pulse. Temperature indicates pancreatic abscess which needs laparotomy and drainage. For D is drugs, that is prophylactic antibiotics in case of severe pancreatitis, for example ciprofloxacin with metronidazole, pethidine for pain, insulin for hyperglycemia. And for E is exploratory laparotomy only when diagnosis is in doubt or when patient is not improving or when there is complications of the pancreatitis such as pancreatic abscess, fistula or necrosis. For F is fluid should be given early. Rapid infusion of 3 to 4 liters of the ringed lactate is used to treat hypovolemic shock. Plasma or albumin may also be given. Now, what are the complications? We are having local complications and systemic complications. In local complications, acute fluid collection, sterile pancreatic necrosis, acute pseudocyst, pancreatic abscess, pancreatic ascites, pancreatic effusion, and portal or splenic vein thrombosis is done. Occur as the complications. In systemic, we are having the pulmonary, that is pneumonia, atelectasis, and acute respiratory distress syndrome. In the cardiovascular, we are having hypotension and shock, and hematologic, we are having the DIC and gastrointestinal hemorrhage. Then the oliguria and renal failure. Then the metabolic, we are having hyperglycemia and hypocalcemia. In central nervous system and psychosis and fat emboli and fat necrosis, that is intra-abdominal superficial subcutaneous tissue necrosis. So these are the complications. So we have discussed the most important topic in the upper GIT, that is acute pancreatitis. We have discussed the scenario, then the definition and the causes. The causes can be remembered by get smashed, mnemonic. Then we discuss the clinical features, then the investigation options, then the lab diagnosis, the serum amylase and lipase, ultrasound abdomen, the CT scan, the laparotomy, the X-ray plain abdomen, blood and urine examination, the serum calcium level. And the assessment of the severity is done, the mild acute pancreatitis and for severe acute pancreatitis. Then Ranson's criteria is checked at admission at 48 hours, and the mortality rate is the mortality rate can be assessed by from the Ranson's criteria. Then the Glasgow scale criteria at admission and within the 48 hours. Then we discuss the management options. It is given as A, B, C, D, E, and F in the sense general. Then the complications are checked, which are having both the local and systemic complications.